Georgina, I don't know how much help we were in your argument with your sister.
She's just going to play this video. She's just going to show up at Thanksgiving and play this video. We'll be getting an email from the sister here pretty soon.
Yeah, exactly.
That would be great.
Good luck. Sorry about that. This is Generation Health. We bring you the latest news, cutting-edge research, and time-tested best practices helping you live a longer, healthier life. With me, as ever, Dante DiMatteo, PharmD. How are you?
Doing all right. How about you?
I'm good. Joey DiMatteo, PharmD board-certified clinical nutritionist. How you doing?
Doing great today. Thank you.
Excellent, excellent. Mic number 4, Josiah Schweinberg, engineer extraordinaire. Sorry, I almost didn't say it.
That's all right.
I got excited by your hand gestures.
He knows.
Extraordinary guy. I'm doing well. Glad to be here as always.
Excellent.
And I actually think, you missed the memo on the shirt?
I did. I missed the dress code update. I'm sorry, guys.
Yeah. Mine's like a green. It is like a yellow green.
I literally don't own a shirt that color.
Well, if you can purchase Tyler a shirt that color, you can email us questions at AskJoeDiMatteo.
Like a light tan. He doesn't have any light tan.
Oh, it's true. It's true.
And Tyler, how are you?
I'm good. My name is Tyler Andrews. I'm somehow supposed to wrangle all of this. We are doing a question and answer episode. It's been a long time since we did one of those, and the questions kind of piled up. Sorry about that. But we've got a bunch of them here. We're going to try and get through as many of these as possible. So that being the case, we're just going to skip all of the warm up, and you guys, I hope you're ready, because here we go. First question. This one's from, I don't have a name on this one. Sorry.
Customer.
It's from a customer.
Let's give him a name.
Steve.
All right.
All right. I'm writing that down so I can remember it. Steve, my 5-year-old son's Asthmanex HFA is currently back-ordered. This isn't the first time, and we're likely to need to find an alternative. What do you think his options are? Is there much difference between Flovent and Asthmanex? Thanks, Steve. Thank you, Steve. All right. That one, I can't help. What do you think, guys? You're the pros. Are there alternatives?
Yeah, this is a common question, a common style question that we get in the pharmacy. So while it may not apply to everybody's condition they're managing or specific medication, I think it's helpful to see kind of how this goes in practice.
Yeah, things do go on back order on the regular.
Yes. And for the most part, provided there aren't major cost issues or, things along that line, it's usually a pretty easy switch. As you, after you kind of weigh out the different factors. So firstly, Asthmanex HFA, it's used in the treatment of asthma. It's a maintenance medication, which is important to distinguish. When you think of asthma, you often hear about rescue inhalers and albuterol inhalers, nebulizers, etc. So albuterol inhalers, those are what you would use in a rescue situation, short term. It's not something that you're using as maintenance. Actually, the more often you have to use it, the more likely it is that maybe the underlying asthma isn't being treated as effectively.
Makes sense.
So we're focused on the Asthmanex again, which is technically a corticosteroid. It's used for maintenance. If someone does have an acute exacerbation of their asthma, you would still continue to use this.
Okay.
But this isn't going to be used really as like an as needed thing like the other inhaler would be.
Okay. So this is a regular maintenance thing that hopefully prevents the need for the acute one.
Right. So of course we're talking about a chronic respiratory condition here. It affects the airways in your lungs. It can be easily characterized by just general inflammation, swelling, and narrowing of the airways, which obviously will make breathing a bit difficult. So the goal is to use something like a corticosteroid to manage this more or less inflammatory response to prevent attacks and to prevent symptoms from popping up.
Yeah. So as the lung tissue expands with the inflammation, it leaves less room for air, literally. And that's why people get out of breath. Exactly.
And then a whole cascade of things start to occur. Again, like you mentioned, narrowing, the mucus production is increased, and this just imagine tubes are already narrowed and you have a lot of mucus secretions and such, and it's not it's can be quite scary, life threatening down the line potentially. Something you want to take seriously, and especially in little kids in this case. So if we circle back to the issue at hand here, the medication that's been working well for Steve is unavailable. So this particular person has had to bounce around pharmacies to try and find this particular one. The issue is it's actually this specific dose at the time of this recording is unavailable. So it's available in other strengths, but because the individual we're dealing with is so young, you have to be very careful with dosing. And in fact, I would say based upon their age, that technically this is going to be an off-label use. Actually, these particular inhaled corticosteroids are actually only approved in those in older age categories. So this is being used off-label. There's really already not a ton of options, so it's just a bit of a stressful situation.
Sure.
So the short answer is to at least temporarily switch over to fluticasone or Flovent, which is another, it's another inhaler like this. It's delivered the same way. It's delivered with a propellant, which is what the HFA component is referring to in the name. And you might wonder why that's important. And that's because in little kids, they can't physiologically draw in enough air to make something like a dry powdered inhaler work effectively. There's a lot of different steroid dry powder inhalers, but those are reserved for adults because we have kind of the wherewithal to pull in enough air. Whereas you can imagine dealing with a little one, there's possibly a disconnect there. So switching from the Asthma in this case, which again is mometasone, a steroid, you can switch to something like Flovent or fluticasone. It's a similar release mechanism. There is a generic available, so it kind of falls into it checks the box of being fairly cost effective. Worst case, if by chance the insurance doesn't cover it, so we have that box checked. The only issue is maybe they tried this before. Maybe this is something that they started this particular individual on and they didn't have success with it, or there were side effects, which is certainly possible. Just looking a little bit at the drug literature here specifically, there's a potential risk of increased systemic side effects with fluticasone versus mometasone, which is maybe why this individual's on this in the first place.
Yep.
And when you're talking about young children on chronic doses of steroids, even though it's inhaled, you do run the risk of, kind of adrenal suppression. We're dealing with someone who is growing, and we don't want to interfere with that if we have the choice.
Right.
So if we pretend, we can't, let's just say all of a sudden now we can't, fluticasone's not an option. Well, we can look at something like budesonide. Budesonide is also known as Pulmicort. The only issue with that is they don't make the HFA inhaler that I'm aware of. So there's no propellant. You're dealing with dry powdered inhalers, and you're back at now a delivery issue.
There? Yeah.
Yeah. Budesonide nebulizer solution is another great option. It is a little more time consuming. You need 10, 15 minutes. You need a mask. You need the compressor. It's a bit more of a process to use this. And I could see why parents would much rather use an inhaler with a spacer if they could versus.
Especially at 5 years old.
Exactly. So, but point being, I'm not even going to mention all the options.
Right.
But there are two potential really good solutions here, in addition to maybe waiting this out a few weeks, as we found out that this potentially might come off back order like middle of October. So if it were me, maybe you try the nebulizer thing temporarily. Anymore, you can get a nebulizer if it's not covered through the insurance, pretty reasonable. And I would imagine if this is a condition you're managing in a child, you might already have one on hand. So I think I think that's the gist of it without going crazy.
Yeah. I think that's fantastic. This is a big key in why it's important that you have a pharmacist that you can trust, because these are the sorts of questions, these are the sorts of situations that come up all of the time. And if you don't know your pharmacist doesn't know your situation, when you have a question like this, where are you going to turn to? Mm-hmm. I mean, other than us, obviously.
Yeah. I mean, it can be jarring to be told you need to change your medication, whether it's an insurance issue. I just think one thing I always come back to, whether it's this specific question or in general, when people need to change medications, is when the drug is in the same class, and by class, it just means they work the same way. I think that's what's key to understand, is that whenever you can change to a medication in the same class, it's hard for, a lay person maybe to understand. All they hear is change, different. It's going to affect, especially when you're dealing with a child, it's going to affect my child differently. So this, again, comes up a lot more and more. There'll be 5 different alternatives all in the same class for this drug, and the insurance, like we talked about PBMs before, the insurance may just say, hey, we've got to deal with these 1 or 2, you're taking them. And then people have to change the drug. And I'm not minimizing that there are nuances to some of the side effect profiles. That's how they get approved, but they're basically, generally speaking, the same. And, whenever you're changing within the same class, it's just something I try to emphasize, that this is in the same class, working the same way. It's not a total paradigm shift for the treatment.
Mm-hmm. Fair enough. Okay.
I guess the last great points, I think the last thing that I would add, and I forgot, there isn't in the sort of the guidelines of managing asthma, especially in pediatric populations, there is always the option of doing a combination inhaler. And so this takes something like the steroid that we mentioned. So, maybe it's budesonide, maybe it's fluticasone or mometasone. It just depends. There's many iterations at this point. I feel like we're more familiar with those that are used in adults than some of the,
definitely,
the pediatric populations, but it's just by chance, I guess. So if we are getting to the point where theoretically they could maybe change up how they're managing the condition here. Maybe there's been more frequent exacerbations. Maybe they're starting to play sports. Maybe who knows? Maybe there's more nighttime awakenings due to shortness of breath. There could be, a combination of issues occurring here. So because of the age, you still would want to be careful. Some of these uses might still be technically off label, but again, you could do something like a Symbicort, which is a combination of budesonide. We mentioned the steroid, and formoterol, which is a similar drug to what's used in the albuterol inhalers, the rescue inhalers. Oh. Except the main difference is the albuterol is a short acting version used in, kind of acute situations. Yep. And the long-acting form is just, as it implies, a longer-acting way to essentially relax the smooth muscle of the airways, relax the airways. Okay. So definitely not a direct substitution, but again, just maybe the next layer of conversation in an appointment or in just managing this condition.
Love it. Love it. Hope that helps, Steve. This next one we're gonna jump to is an email. This one came to us from our email. You can email us questions at askjoedimatteo.com. That's questions at askjoedimatteo.com. You should visit the website. There's a lot of great stuff on there. Typically, I do the shilling at the end of the episode, but we're doing it right here. Okay, so this question says, "Hello, health team. I had a bout of shingles on my face and scalp a couple of weeks ago. I'm in the recovery phase, but I am having terrible and deep itching sensations that are difficult to relieve, as well as burning at the touch. I'm wondering if there are any supplements that are beneficial during this time to speed along the recovery and/or can offer relief. If so, I'd love to know what and what dosages. Thanks for all you do for the show and your listeners, Lindsay." Thank you, Lindsay. All right.
Yeah, that's a really good question.
Shingles.
Shingles. Yeah, we hear that a lot. As that kind of varicella zoster virus kind of reawakens in the nerves, it causes inflammation and damage. And that is where that pain is coming from. More severe cases can certainly, lead to almost like a nerve injury. Okay. So from a supplement standpoint, that's where it gets, that's why it's a good question, gets a little muddy. The antiviral use is critical, especially within 72 hours, but we're obviously way past that.
Right.
So how do you manage this? Medications like gabapentin and pregabalin, which is Lyrica, those are, relatively speaking, heavy hitting medications. I could see in this case wanting to avoid those. So assuming that that's the desire here, based on the question, I think there's two ways to look at it.
Okay.
There is a medication, quote unquote, way that is topical. There are lidocaine or capsaicin creams, even patches is not going to work on the face, but probably wouldn't be ideal.
Yeah.
But a cream, yes, it's medication. There's no systemic absorption. The lidocaine, obviously, when you hear any medication topical with the word cane, is numbing. Capsaicin works by a unique mechanism, blocking substance P. It kind of can give you that little bit of burning initially, which is jarring. But it does last and kind of work via that substance P mechanism. So that seems counterintuitive, but there are studies, there is data showing that does help. But I could see, given that, maybe starting with the lidocaine. So yes, that's in the med realm, but it is something that, as a pharmacist and nutritionist who does specialize in this area, that I recommend.
Yeah.
I really would, in this case, using a topical medication like lidocaine, get some relief. From a supplement standpoint, it gets slightly difficult because she's asking about a specific condition, this kind of post-herpetic neuralgia. A lot of the studies that show benefit related to neuropathy or neuralgia in general are really related to diabetic neuropathy or idiopathic neuropathy. So there's, I think, very reasonable assumption of crossover between those things, knowing just the mechanisms of how these work. The only concern that I would have is, and that's why I started with the lidocaine, is time. So this is not a situation where, hey, I have diabetic neuropathy that has been progressing. I've been dealing with this. This is likely going to last a very long time and be something that's chronic for me. A supplement regimen that works, but that's going to take some time, is managing this chronic, potentially lifelong situation. It's not ideal. You want it to work right away.
Sure.
But that's just where you are managing a chronic condition. Post-herpetic neuralgia is a little more complicated because that is, while not acute in the sense of, a couple days severity, that's more in the weeks and months, just really varies. In the weeks and months realm, to get supplement benefit is a little more difficult. That said, lidocaine, first recommendation for you, avoiding the meds, but supplement wise, alpha lipoic acid, good forms of B vitamins, particularly methylated cobalamin or B12 in that methylated form. Again, along with alpha lipoic acid, acetyl L-carnitine have all been shown, to have success in post-herpetic neuralgia. With limited evidence, I would say, relative to where the evidence is for more of a chronic condition like diabetic neuropathy. We do carry a product that has these things combined. Neuro Renew is the product, and it is a nice combination way to get all of these ingredients together. So the short answer, direct supplement, Neuro Renew. It has the alpha lipoic acid. It has this the methylated forms of B12, also of thiamine. It has a more active form of alpha lipoic acid and the R lipoic acid active form. So that's pretty direct. Back to what I said 3 times already. Lidocaine. Put some lidocaine cream on. I really would. That's going to help you, and especially, I like the concept of a bridge. Yeah. So you have this pain that can last for the next weeks or months. You've got this bridge lidocaine just to get some relief immediately. And then you take some supplements that, honestly, especially the methylated Bs, are good for you anyway.
Yep.
And you hope that you get some more longer term. Maybe you shorten the duration of this post-herpetic neuralgia and go from there. I think it's a nice combination.
Love it. Love it. Lindsay, good luck. That is rough. I'm sorry you're having to deal with that.
It is.
Oh, man. Okay, how about this one? Are there any studies? This is from Bev. She messaged us on Facebook. Thank you, Bev. She said, are there any studies to support my investment in a vibration plate? Since we're seniors, are there benefits or cautions? That is Bev. Thank you, Bev. Vibration plate. I've seen those online. I've never stood on one. They look fun.
Yeah, it seems like there's some evidence to suggest that they're doing something. It's just to the extent at which it can improve things like flexibility, mobility, actual strength outcomes. That's what, that bone density, those sorts of things are where it's a bit more controversial. So, I think the first thing to look at is like, what's even happening with one of these? So sometimes they're just we know them as like whole body vibration plates or vibrating plate machines, whatever you want to call it. It's designed to just stimulate the musculature of the body through mechanical vibration. So they can sit, stand, whatever on one of these plates.
And it just vibrates.
Yes. And there's various speeds and intensities. And then, there's hopefully a response at the end of doing this. So depending on where you look, you've seen people claim that they've lost weight doing this, it's improved their lymphatic circulation, etc. All those sorts of things. This is one of those topics where you can really get lost in the weeds. So I would just like to maybe for now keep it in the realm of, will this help somebody, let's say, meet the physical activity guidelines? So
and she's a senior.
Right. So again, the effectiveness of this, it just depends again on what you're sort of looking for. So you can really crank these up to some different higher frequencies and such. If it's below 20 hertz, this is more like rehabilitative in nature. If you ramp it up above that, greater amplitude, you can, this is where you see more of the, hopefully the benefits in musculoskeletal strength and, bone density and those sorts of things. I just don't know.
How long have these existed? I've never heard of this before.
I never have either.
They've been around for a while. Yeah.
They've always just struck me as, you remember the vibrating belt things that from the 50s that were all the rage for a minute, and they were supposed to vibrate your fat off. Do you know what I'm talking about?
I know what you're talking about. Yeah.
So, if we think about what's happening with one of these, I think one of the biggest benefits for somebody, maybe the elderly population too, is just balance and stability. Theoretically, that, this population's at greater risk of falls and having issues that stem from these falls.
Sure.
So if you're standing on an unstable surface, you can make the argument that this might make somebody better equipped to handle stuff that pops up in life. But again, if we're looking at, comparing this to traditional resistance training, cardiovascular exercise, there's just nothing that shows that this would be better than such an intervention. So if we look at Bev's question, if she's coming from a place where this is her entry point and, she's willing to spend the money to do something like this to start, then I think, hey, knock yourself out. Just knowing that this is more of a tool in the overall picture of physical activity.
So if the goal is to increase stability and strength and musculoskeletal density, if I hear what you're saying, sure, fine. That maybe this is a good place to start, but this is not the place you want to. This is not going to do everything you need it to do.
Definitely.
Yeah, it seems like one of those questions where, again, I'm reading too deep, but this type of question is like a vibration plate. I would like to do that because working out and exercising is hard. So will the vibration plate take the place of those things, right? I mean,
that's what I hear too.
That's what I hear.
Yeah.
And I think it's like Dante said, it's a nice adjunct tool. And I think potentially, looking at somebody who's not moving, I think of even relative I have, et cetera, they're not moving at all, basically.
Yep.
That maybe starting here is not a bad thing. At least it's something to get even just from the blood flow aspect, the stability, getting used to, standing if there's any mobility and walking issues. But yeah, I just think it needs to be an adjunct or a start. It's not that solution. It's not the replacement.
Yeah.
Exactly.
The only reason why I asked about how long they've been around is because I don't like how much data can you really, or trials or tests can you really have? It hasn't existed that long.
And I was curious too. I mean, you can get one at Walmart for $60 and you can get ones that are upwards of $2,000. So, the 60, ones that are $60, $100, that investment may be, certainly a lot less. That could be, the starting to move up, and I don't have all those details and really what the difference is, but you always have to weigh a cost benefit too, literally in this case of cost, and where are you going with that? So it's reasonable. I would say that, if you look these up and they all started at 1,800, maybe it's a much lower adjunct tool, maybe recommendation, but you can at least maybe get started with one at a pretty decent number.
Fair enough. All right. This next one is an email from Georgina. Georgina emailed, she said, last year, this is a big one, so buckle up. Last year at Thanksgiving, my vegetarian sister-in-law overheard me telling my 8-year-old son that 2 trips to the veggie tray was sufficient until after he had some turkey. She immediately jumped in to question why I would discourage a child from eating vegetables. When I told her he needed to eat protein as well as veggies, she said he would get plenty of protein from the broccoli. I laughed in her face, something I love doing. Oh, Georgina.
I like all the details in this one. This is good.
This is good. Write lots of details in your emails so we get to laugh more. Before asking just how much protein she thought a young boy should eat. She never answered the question directly, but insisted that we've, quote, been sold nonsense by big food that's putting protein in everything so they can convince you it's healthier, unquote. She swore she'd seen studies showing that we only need a little bit of protein to stay healthy and build muscle, amounts she felt certain could be reached with beans, peas, and the occasional egg. Knowing my sister-in-law, she's probably got this from a YouTube influencer, so I'm asking another YouTuber. Oh, thank you. How much protein do we really need? Any research or studies you've got would be appreciated. I plan to print them out and bring them next year.
We got you.
Oh, that's fantastic.
Wow.
All right.
Of course, this would happen at Thanksgiving.
Look, that makes sense. You bring families together. There's lots of food. Hey, points for the kid that's eating lots of veggies. That's very cool.
I would say at least she cares about your child.
I'm sure that's the point she's coming from, right?
I'm
sure it's all about care.
Love.
Yeah,
it's not. There's nothing.
We'll give her the benefit of the doubt.
Yeah. All right. So how much protein should an 8-year-old boy be eating? And can you get it sufficiently from beans, peas, and the occasional egg?
The short answer is somebody of this age would need only about 20 grams of protein per day.
Okay.
As the RDI, so the recommended dietary intake. This is the base level for supporting growth, tissue repair, just, surviving essentially.
Sure.
So obviously we would recommend a good bit more of that. But again, I think that just sets the stage that in a 4 through 8-year-old, we'll say they don't necessarily need to be super worried about this, like somebody who's bodybuilding and, cutting weight.
Yes.
And that sort of, because we don't want to create a generation of protein weighers like ourselves. You know what I mean? So
I think there's worse things we could do.
I was just going to say, it could be a lot worse.
Yeah. So when you think about what 20 to 30 grams of protein really is in real life, it's about a 3-ounce serving of turkey. So it's a fist size amount of turkey. It's not a whole lot. I think most 8-year-olds can finish that at a dinner, or if you think about splitting that twice a day.
If you add an egg in the morning and then some turkey,
right. So it's not a whole lot. Kind of at the end of the day, as far as giving like a recommendation beyond that, I just don't know if you can kind of extrapolate what you would recommend an adult. The whole 1 gram per pound body weight, etc. Is there a perfect number? I don't know what you kind of came up with.
Around where you did, I saw, and of course, 8-year-old is the cutoff.
Right.
So I saw between 4 and 8 years old, 19 grams, and then from 9 to 13, 34. That's a pretty big jump. So Dante kind of settled on 20. And I would say that, makes a lot of sense in terms of, 20 to 25. Because for an adult from the same standard RDA is 0.8 grams. So
I know for a fact that in a couple of years, and you know this too, you won't be holding that child back from eating anything.
Oh my goodness.
A
Boys.
10, 12, 14-year-old boy is going to eat all of the things, turkey, vegetables, all the stuff. All of my kids grew out of their food resistance. The thing where they're like, I don't want to eat that. They all grew out of it when they hit puberty and they just couldn't stop eating. And they would just, it doesn't matter. I'm going to eat that too.
My grocery bills are through the roof.
It's crazy.
Yeah.
I thought the one thing that was interesting was the comment that I'd like to talk about sold nonsense by big food that's putting protein in everything so they can convince you it's healthier.
Yes. Yeah. Well, look, I love protein potato chips. I think that's the healthiest thing ever, right? No, that's not what I mean. Personally, because I am trying to eat a lot of protein, I do like that it's added to a lot of things, but I also understand that just because you put protein in potato chips does not make them healthy.
Yeah, and I think it's almost like a little bit of like analogous to the fat-free craze of like, oh, let's stamp fat-free on Sour Patch Kids labels. Like it's not analogous to that. It's not. They're putting protein in. I mean, on the better end of the scale, Dante probably has way more examples, but like oatmeal, adding protein to oatmeal, an already healthy food. I think that's a great thing. Adding protein to potato chips, not as great, but as long as you're understanding that the core of what you're eating is oatmeal versus potato chips,
right,
then the rest can become details. So I think that, is there an element where marketing is aggressively adding some protein to maybe some things that aren't healthy? Is there some truth to that comment? I'd say so. But is there a lot of benefit to that push? I think there is. I think there definitely is.
Yeah. The thing that I do find interesting about that, because I'm their biggest customer.
Yeah.
Me
too.
I mean,
so I kept looking at you.
Admittedly, it's like, oh man, they added 20 grams of protein to this pint of ice cream. It gets me every time.
Yeah.
But in general, if you look at the modern the modern American diet, it's really not that. The average person is not eating enough protein, because really we eat, I'm a little maybe off the evidence base here, but we eat as much red meat and consume as much meat in general as any other country, I would say, for the most part. So even if you're just looking at it from a macronutrient perspective, sure, we probably eat a little too much saturated fat. We're probably eating too much added sugar, all the things. But I don't really think that there's a general lack of protein, really. It's where do we see that come up as an issue? It's underserved populations. It's food deserts. It's where there's like a real true nutritional need. It's very unlikely that, someone who's in this environment who's maybe overeating, they're eating at a caloric surplus, there's a mismatch between their appetite and what they're eating. If they're in that boat, I really, really, really do not believe it's because they're not eating enough protein. So it is just funny to see that there is a push of putting protein in everything, but it's really just to appease those who are, it makes you feel fitness focused or health centric. It just caters to that, to that way of thinking.
Yeah. The child aspect is interesting because even just knowing from, the day-to-day routine of young kids, it can easily turn into, I try to do better versions of this, better forms of bread, et cetera, but it can easily turn into toast in the morning or a bowl of cereal. And then what do you want for lunch? Turns into noodles. Like it can go, or fruit. And you say, well, they're eating fruit. That's great. And yes, that's great, but no protein there. It can easily, if your child or you don't have it available for whatever reason, and your child's not big on the chickens, the turkeys, it can spiral on you quickly. In terms of just getting through your day, what do you want to eat something, not having much protein. So if this child, had toast in the morning and then goes to Thanksgiving dinner and just wants vegetables, there could be an issue there, day to day. That's just, again, where things get so individualized and where with children it gets more complicated.
And exactly. And even at that, if we just go back to the RDA perspective, which is the bare minimum. Let's just say you are just eating toast. You're just eating oats, cereal. I mean, there's still, it's not known for being a source rich in protein, or not even the most optimal balance of amino acids. Let's say if you have a big bowl of cereal, between the milk or the almond milk, the cereal itself, I mean, that's 7 to 10 grams of protein. And then if you have oats, 5 to 10 potentially grams of protein. Even rice, if you have a hearty serving of rice, let's say, like, you're still picking up we'll call them trace amounts of protein. So it's pretty
interesting. So
it's pretty dang hard to not get enough protein. But if you're looking at just something a little beyond that, what's going to set my child up, maybe who's now a little more active. I want to put more a variety of health promoting foods in front of them. That's where, healthy peanut butters and almond butters and different nuts and seeds and those sorts of things can really round it out. It's like, do you really need to add the ice cream with the extra protein for a kid? It's probably unnecessary.
Not for a kid. It's too expensive for them.
Yeah.
Much too good for children.
Yeah. But it's the reality is that, like, every decision, or at least me personally, it seems like there's a spectrum of, like, good to bad, and nothing is absolutely bad and nothing is the most perfect choice. And so it's just always like, hey, if I walk into the gas station and I'm really pressed for time and I need a good snack, I'm going to pick the stupid protein Pop-Tart every time. Like,
100%.
I'm just conditioned. I'm conditioned at this point. If it says 20, I'm over protein bars, of course.
Yeah.
But if they change the shape and they make it look like a regular Pop-Tart, then I'm your guy every time.
Yep.
So it's, again, the spectrum of options and choices, the better choice would be grab the banana, grab the apple, maybe a small protein drink, or a milk. I don't know. You can make a case for that. But instead it's like, is it that much worse to just do the protein Rice Krispie treat? Is it the end of the world this time? I don't know.
Well,
you got to have options.
But compared to the straight Rice Krispie treat, look where you are. Right. That's why I have a hard time.
Right. It's like your spectrum of choices. You got two. You got one right next to you. One has a little more protein. One is a little bit more protein deficient.
Yes, that's why I did jump on that comment about the big food overhyping protein. There is a thread of truth, but it is not fat-free Sour Patch Kids. It is not same type of marketing and not the same type of overall health benefit. It's just not.
Georgina, I don't know how much help we were in your argument with your sister.
She's just going to play this video. She's just going to show up at Thanksgiving and play this video. We'll be getting an email from the sister here pretty soon.
Yeah, exactly.
That would be great.
Good luck. Sorry about that. Hey, it's only one day. You get to control your kid's diet the rest of the time, so don't worry about it. All right, moving on. We've got this one from Erica. I'm not sure if this was this might have been an email. We're going to say it's an email. Erica probably emailed us questions at askjoedimatteo.com. That's questions at askjoedimatteo.com. We need your questions too. We take them very seriously. Okay, here's what she said. For years, I've been struggling with my weight. Diets just seem impossible after a few days. My doctor has suggested starting Wegovy, and I told her that I would seriously consider it and began doing research. One Google search later, and I was horrified to find numerous headlines about the side effects. Things like blindness and major tooth problems are being thrown around, and it's honestly making me really nervous. My doctor told me about the potential of nausea, but the thought of losing my eyesight or having my teeth fall out is obviously a huge deterrent. Could you guys possibly dedicate some time to the podcast to address this? I know you've talked about hyped up headlines, but this is freaking me out. Are these actual risks? Thanks so much, Erica.
There's obviously a lot of different angles we can go in here, and I'm sure we will, but I'm just going to jump straight to kind of the scary headlines to the blindness and teeth loss.
Pulled a bunch of them up.
Yeah, and I think the blindness part, so there are a few case reports. What it's coming from, though, is for diabetic patients, okay, whose blood sugar improves very rapidly. They have some degree of a condition called diabetic retinopathy. It seems counterintuitive, but it is an eye disease caused by diabetes. But if the blood sugar is improved very rapidly, it can create a little bit of an exacerbation. There's a lot of changes physically on the eye at that point. So there is a link there. But essentially there are no case reports, like at all, for patients who do not have that diabetic retinopathy condition. And that is just one of the many reasons why, for anybody going on this drug, for whatever reason, whether it's straight blood sugar control, weight loss, a combination, is that you start low. You start low. So the key word with this is blood sugar improvement very rapidly, which will not occur if you're following a standard starting at low dose, titrating up aspect. The dental and tooth problems is a similar type, maybe not as direct of a cause, but these are typically caused by severe nausea, reflux, vomiting, as a very intense change in hydration levels that can occur whenever you start these, reduced food intake. There's no direct mechanism or real evidence that it's directly caused by the semaglutide or tirzepatide. It would have, could be, if it's kind of come with the starting of the medication, would be probably related to those types of changes. Okay. That's the only thing that I could find related to maybe a direct answering of those kind of scary headlines. There are other things to be concerned about and to weigh, and we can go into those, but I just wanted to jump right into those heads, because that is what can grab you. And I think it's always a case of very popular drug being pushed, so to say, on one end by pharma, by clinicians who are seeing great results from it. Then there's everything's still a business. Who can create a business on that side? We just went over that. Who creates a business on the other side in media, on YouTube videos, on TikTok? It is those scary headlines. It is those types of things. So whenever a medication starts to rise in esteem, and is being marketed, then you're going to have this other side nowadays in the way our media is, where these things can become so much in the forefront at a Google search. And I just think it's important to understand that there are issues, yes, but those severe ones, they don't quite add up to reality of true, genuine risk.
Something people need to be. So just going over what you said again, just real quickly. So you said the blindness issue was specifically people with diabetic retinopathy, and it's a result of rapid improvement of blood sugar.
Yes.
So if you don't have diabetic retinopathy, this is not something you need to sweat. If you do, obviously you should be talking to your ophthalmologist and doctor about all of those things. And then for the teeth issues, you said it was vomiting and nausea and like dry mouth.
Yeah, dry mouth can, lead to decay. So usually there's some underlying issue already related to tooth decay, to gum issues. Then a pretty intense, what can kind of come together of severe nausea, reflux, vomiting that can genuinely occur with these medications. Absolutely, those are valid side effects you should be aware of. Another reason to titrate up slowly. Then you combine that with significantly reduced food intake, a lot of changes in the mouth, reduced hydration. With these meds, you want to make sure you're hydrating. It can potentially exacerbate kind of as a secondary cause.
So again, people just take it low and slow and don't be in a rush.
Yeah. And hey, if you have some issues with your teeth that are already that you're already aware of, and those are going on, it's something to be aware of. But I think to me, the question is asking, like, I have healthy teeth and all of a sudden these people started taking this drug and their teeth decayed. That's
not what's happening.
No.
Got it. All right. That is very helpful. Erica, I hope that helps. Good luck. All right. This one comes to us from Neil. He said, while at my annual physical, my doctor suggested that I look into hypertrophy training. I'm 69 years old, very active and in very good health. As someone who has never worked out before, the idea of starting now is pretty intimidating. What exactly does hypertrophy training mean? Can you recommend a set of exercises that I could use to get me started? I'm open to any and all suggestions, as I have no idea what I'm doing. I never thought my late 60s would be when I started lifting weights, but here we are. Thanks in advance, Neil. All right. Well, that one, I guess that's Dante. What you got, Dante?
I was actually thinking I'd take this
Do you
one.
want to take that one? That's what I should have done. Josiah, what you got?
So yeah, he's asking, and I guess initially, what even is hypertrophy? What is hypertrophy training? This is basically just referring to the muscle fibers growing in response to in this case, a training stimulus. So if your doctor perceives that you need to put on a little more muscle mass, a little more size in general, this is the primary objective. So,
and the reason for that, especially as somebody ages at 69 years old, is muscle loss is an issue in general, and osteoporosis and osteopenia are largely addressed by increasing muscle mass, correct?
Mm-hmm.
Okay.
Yes. Now sometimes the issue with delineating these things is that any sort of training at this point, in this individual, provided they do enough reps, provided they get close enough to failure, they will likely experience hypertrophy gains. They might experience changes in bone density. They're also going to get stronger. So to think that there are these training modalities that we can perfectly isolate is just something I think important to highlight sometimes. Now, how you manipulate certain variables, you can maybe change the desired outcome a little bit. But just because you see somebody doing sets of 4 reps, that doesn't mean they're just not training any sort of hypertrophy stimulus. Just because you're seeing somebody train 24 reps, that doesn't mean they can't also get stronger. So if you just look at it as, hey, if I get in there, start lifting weights, I choose something that's adequately stimulating, then I'm likely moving closer to this, stated hypertrophy goal. So this is a pretty intense, I think, physiologic topic. I mean, there people devote their whole careers to understanding hypertrophy, what happens at the level of muscle, what are the key drivers of hypertrophy. On my Instagram, it's widely debated how this is occurring. It's like insane. Yep. So this is another one you can really get lost in the weeds, but I think it's just, again, important to highlight this general process. You, by exercising, you have a kind of a controlled cycle of stress. Stress causes damage, and then you repair. And then by doing the resistance training, you're putting the muscles under enough mechanical tension by, exerting force against that said load. And then this kind of damage that occurs, this tension occurs, then your body just views that as, hey, now it's time to rebuild. Now it's time to repair. Now it's time to do what we need to do so that when this happens again, we've mounted a better response, essentially. And now what's debated is it the muscle tears, or is it the micro tears that eventually cause hypertrophy or cause us to get bigger? Is it just mechanical tension? Is it just volume? There's all these different things that maybe we don't have the perfect answer to. Right. So that's why I think for most people, it's not even worth worrying about it. Like, hey, am I doing enough hypertrophy training? Am I doing enough strength training? So if we distill that down to, if you're between 6 and 30 reps of something, and let's say, it's a machine press. It's just a machine press, and you're doing somewhere in that range, we'll call it 10 reps. And as long as you're getting within a few reps of failure, and it will take some time to
failure, literally meaning you can't get it to move the way it's supposed to another time.
Mm-hmm. Yeah. And I think that even, we have to be cautious in this instance too about some of that terminology. You start to hear failure, you're like, see, this is kind of why I didn't want to do this in the first place, is people are pushing themselves way too hard. It's just the idea of trying to understand, what your limits are. And also, again, over time, you're going to have to, believe it or not, progress this to continue to drive the stimulus to get the desired outcome that you want. Right. So if you're staying at the same, it's certainly better than doing nothing, but if you stay at the same weight, the same reps, the same difficulty over and over and over and over again, at some point you're going to have to change the stimulus in such a way that matches what your new level of fitness is. Right. Basically. So when we think of failure, Don't let that scare you. It's just, you can just feel it starting, your reps start to slow down.
Yeah.
If you notice it's getting a little harder for you to get it to the top, doesn't mean you cut the set there, but you just get in tune with those feelings, and that you ideally, you're going to be coming back the next day or the following day, that if you're pushing everything to absolute failure, it's going to be hard to stay consistent. So there's also the angle of managing the fatigue of the stress that you're putting yourself under each time.
Yep.
So you'll find that it's this constant balancing act of, am I paying too close attention to how, close I'm getting to failure? Is this, am I not paying enough attention? The idea is just get somewhere close, pay attention to how your last few reps feel, train in the rep ranges of 3 to 4, 6 to 8, 10 to 15. You can mount,
change it up.
You can mount a hypertrophy stimulus in any of those rep ranges. Again, provided you get close enough to failure, provided they're hard enough, provided there's enough tension on the muscle. It's a movement like you and I have talked about, that you can actually load. It's not like a stability plate, let's say.
Yeah.
It's how much can you really load that. How much can you progress it? How much can you load it past a certain point?
Right.
So these are just some of the questions, some of the things to be, thinking about. And while the nerds can worry about hypertrophy training and what to debate and what's the best, what's the worst.
I love the idea of nerds worrying about hypertrophy training.
I was going to say, you are one of those. I think a little bit.
Anyway.
Yeah. You just need to know that if you're going in there, you're just hitting the, 3 sets of 10, that can be hypertrophy training. 3 sets of 4 to 6, that can also be hypertrophy training. You just have to make sure you're going in enough times throughout the week, throughout a month, that you also are accumulating enough stress and enough volume across a bunch of different muscle groups that, that you can actually.
It drives adaptation.
Exactly.
So you're saying it needs, or it should increase and progress? Like, is there a point where, age or that becomes a factor?
Ooh.
You know what I'm saying? Like,
that's a good question.
If this guy's 69, I'm assuming he's in great shape and he's starting all this. What happens when he's 75?
Mm-hmm.
Like, is there a threshold maybe that you shouldn't be taking on, 120-pound bench press or whatever? Like, you probably shouldn't be doing this much of a bench press.
This is a great question. You have to, in my understanding, is you actually have to flip this on its head, because like you mentioned, as we age, we're resisting this degradation that we perceive as occurring. Right. And so sarcopenia, anabolic resistance, we're a little bit more resistant, or we're less sensitive to certain physical stimuli. So given that, if anything, in a theoretical sense, for somebody who's aging, just depending on where they fall, what their background is, there may be limitations, health conditions, etc. If anything, that dose might need to be higher than you think, because they simply can't mount the same response that a 22-year-old would to the same kind of training. Now, that doesn't mean that if I bench 225, when Tyler turns 70, he's got to bench 275 because he's less sensitive. No, it just means that it doesn't mean the opposite, because a lot of times what happens is so-and-so's older. We just got to be careful. We'll just stick to bands. We'll just stick to vibration plates.
Yeah,
we'll just stick to, that's the issue.
Yeah.
And it's like, it sounds like we're crapping on those things, but it's really just that it's just, you have to flip the way you're thinking about this stuff. You are theoretically less sensitive to the thing that is supposed to be stimulating some sort of response. So you got to make sure you're giving enough, right? And it's the same way that if you are an advanced athlete, let's say, and 3 sets of 10 on the shoulder press may not be the thing that's going to make your shoulders bigger anymore.
Right.
You might have to add more sets.
Yep.
You might have to add a second exercise targeting the same thing. You might have to go to the gym more times a week. It depends on what you really want out of this.
Yeah.
But the point is, it's, whether you're really advanced or you're really new or you're really old, there's a there's an acknowledgement that's required to say that, hey, like, I'm less sensitive. I'm potentially less sensitive. So I have to really be cognizant of progression.
So helping Neil specifically here, because if I hear you correctly, you're saying basically don't overthink it.
Mm-hmm.
Get in there and start moving weight. That's whatever you do, especially as a beginner, it's going to help. I know you, so you're going to say recommended movement guidelines, try and hit those.
Mm-hmm.
Are there any specific exercises that you would point a beginner to as a good place to start? Here's a few things that you can look into and work on that will get you started.
Yeah. I think whatever appears to be the least intimidating initially, maybe that's something, when I say intimidated, that doesn't mean like, oh my gosh, it's the scariest exercise ever. Like looking at somebody doing a clean and jerk.
Yeah.
It's saying that like, what's going to be easy for me to set up, what's available in the gym. Like that's how simple this needs to be. What's available, what have maybe I had some experience with before? What's my partner that I'm with going to be interested in doing? So for a lot of people that is starting with machines, it's loaded with a stack. You're not carrying plates around. You're not like feeling like you're out in space initially.
You can't move it too many different weird directions.
Yes.
It goes in one path.
Yeah, exactly. And then personally, coming from at this point, a CrossFit background, there's no machines in those gyms for the most part. Our gym has machines, but it's a lot of them. It's free weights, it's barbells. You're in space, and I love that stuff. That's great.
Yeah.
But for a lot of people, that's a little scary. So if we pretend you're that person, just pick the thing that's loaded and kind of set up for you. And then again, in the same sense that you need to progress, add load, add sets, add weight, add a second day a week, all those kind of things, you're going to need to change the stimulus. And so it might be 3 weeks of a leg press in a controlled environment where you're just adjusting the stack.
Yep.
And then eventually it becomes since we're using legs as an example, maybe it's a sit to stand squat. And it's hey, now I'm a little more confident in what my legs can do. I'm not going to go front squat, but I'm going to at least do sit to stand with a kettlebell, or sit to stand with a barbell on my back, or however you want, in a suit, holding it like 2 dumbbells in a suitcase, something to load the squatting pattern, something to, load your lower limbs, your hips, the things that are very susceptible to injury, down the line. So there's 1,000,001 examples. There's no bad exercise really. It's just finding the one that you're least likely to, make an excuse about.
Yep. Love it.
Yeah. And no, Josiah, did that answer your question a little bit? Cause I love that like theoretical argument.
Yeah, no, I thought, as people get later in age, of course we want to encourage continued activity, but at some point, like, do people start recommending like, you probably shouldn't be lifting that. Your bone density is, I don't mean to sound it like in a condescending way, but what I'm saying. Like,
do people say that? Yes.
Yeah. And
are they right?
Yeah. And it's not that you wouldn't acknowledge that. It's just that eventually you realize that people are sometimes a little more robust and a little more capable than you might think.
Well, the whole point is your body is supposed to adapt. And if you haven't driven any adaptation for a long time, you're not going to go immediately try and bench press 220, 230. How many do you put on a bar? 135, 225. You wouldn't immediately go and try and bench press 225. You would progress to that. So on an individualized basis, is somebody in their 70s or 80s or 90s going to start real light? Yeah, of course. Of course. But that doesn't mean they can't start. And once you start driving adaptation, you still have to account for, okay, now you've adapted. Now you have to have more load.
Yeah, I think about that video, that woman that you showed me. I don't know what her age was, but
there's a couple of them that we'll share at some point in time.
Okay.
But women that are in their 90s and 100s are competing in strength competitions, and they look like your grandma, and she's the strongest woman in North America, ostensibly, because there's nobody else at 98 years old competing in strength competitions. But it's amazing stuff. It's really, really cool.
Yeah. And yeah, the other part of that's interesting is that Well, I'm older and I can't possibly hit a PR, or I can't possibly move enough weight on something that I would even feel good about. I'm getting older. I'm weaker. It's just those days are behind me. Well, I mean, not really, especially if you're not coming from a background that is like years and years of strength training. So you will surprise yourself that into these later years that you can make substantial improvements again, because you're maybe not coming from the highest starting point.
Right.
The interesting part are those that have 25 years of deadlifting 600 pounds under their belt, how they, what's the psychology around declining performance in their 60s and 70s. They tied years and years potentially of their self-worth into their deadlift numbers, that now they're only doing 225 when they're 70. It's like, it's weird how that line sort of blurs.
Absolutely.
But the main takeaway there is that you can surprise yourself and PR all sorts of weird things. There's a million and one things to, break a personal record on and feel really good about. And again, especially if you're not coming from this huge base of strength, that's the key. So if you've been doing this a long time, forget it. You're in big trouble.
You've played the head games.
You've already peaked. It's all downhill from here.
Tell Neil, put your headphones on. Don't be intimidated. Get in there. Put your headphones on. Keep your head down. Just do your thing.
There you go, Neil. Awesome. Thank you so much, guys. I love doing these. I miss these. Next time we'll do a lightning round. Get really short ones.
Wow.
I'm threatening. That's not going to happen. If you have a question, if you have a question, we want to hear it. Questions at askjoedimatteo.com. That's questions at askjoedimatteo.com. That website is where you can find past episodes of this show, the show that started this, the Ask the Pharmacist show is there, or any of the products we recommend, all available there on our website, askjoedimatteo.com. If you have a question, email us. Also, you can add comments to this video. You can shoot us a message on Facebook or Instagram. We respond to all of those. We would love to hear from you guys. We've got a cat making an appearance, so big thanks to Ghost.
Really likes me.
He has. You've found a new best friend. That's it. I hope something you heard here today was helpful and that you learned something. If it was, share the show with somebody somebody else who needs to hear this. Thanks, as always.
Share it with a friend who's preferably not a cat. Well, that's what we
share it with your cat friends.
Share it with your cat friends, any friends, if it's helpful and beneficial.
This show is off the rails. We'll see you next time.